Welcome to PGOG postgraduate class in obstetrics and gynecology. And today's topic is new cervical cancer staging. Why the change? Cervical cancer staging has been changed as per International Federation of Obstetrics and Gynecology, that is FIGO 2018. And what we will see today is what are the changes as per this new 2018 staging system and why these changes have been made. Importance of staging for any malignancy, it is to decide appropriate management because stage usually directs the treating physicians in which direction the treatment modality, which treatment modality to be used, in which direction treatment usually will be beneficial for the patient. Then to decide the prognosis also it helps. As the stage advances, we know that the prognosis becomes poorer. And to compare the results, especially in research papers or for the future changes in the classification system, staging plays an important role. Why there are changes from time to time in cancer staging are because there are usually advances made in the diagnostics tools, how we diagnose the disease, and also there are advances in the treatment modalities. And to include these changes, usually the staging is changed. Previous classification, which was suggested and followed all over the world for the carcinoma cervix, was FIGO 2009. Cervical cancer burden is more in low and middle income countries, with 80% cases which are occurring in developing countries and only 20% from the developed countries. Because of this fact, mostly clinical classification was advocated by FICO. So up to 2009, minimum investigations were allowed and mostly the classification was based on the clinical findings. But there are significant recent developments which are occurring in imaging modalities, in surgical techniques such as fertility preserving surgery even for malignancy, and minimally invasive techniques used for lymph node assessment. These are the examples. Radiation techniques also, more targeted radiotherapy can be given, and chemotherapy, which further adds to the efficacy of radiotherapy, so that now we call the treatment which is given for cervical cancer as chemoradiation. With these changes, there was a revised classification which has been suggested by FIGO in 2018 for the staging of cervical cancer. What is new in this FIGO 2018 is most important change is imaging and pathology is included along with the clinical staging. So for staging, we can take help of either imaging or pathology is the major change. Whereas 2009, as I said earlier, it was mostly based on clinical findings. Now, this classification provides flexibility to use either clinical or imaging or pathology criteria to stage the disease, to stage cervical cancer, so that there is a flexibility and so that whenever the resources are less in low and medium income countries, facilities are limited, and that is why this consideration is given that we can either use clinical criteria, imaging criteria, or pathology criteria to stage the disease. Criteria to stay in stage 1A has been changed. That is, horizontal dimension is not included now to decide which cases will belong to stage 1A and which will belong to stage 1B. Stage 1B is divided in three subgroups as stage 1B1, 1B2 and 1B3 instead of previous classification where there was a division in only two subgroups. Major changes in stage 3 criteria where lymph node involvement or micro-metastasis, pelvic and para-aortic lymph node involvement is included, as well as presence of micro-metastasis is included to change the stage to stage 3. Stage 3C is the main category which has been added to the new staging, where there is a stage 3C is further divided as stage 3C1, where there is a presence of only pelvic lymph nodes, lymph node metastasis, whereas stage 3C2 is presence of para-aortic lymph node metastasis. Now, which imaging modality to be used to stage cervical cancer? Magnetic resonance imaging MRI is best to stage early stage disease because of better soft tissue resolution. So whether there is a disease which is limited only to cervix, or whether the cancer is spread into nearby vagina or to the parametrium, that will be, or the even the size of the disease, that will be better assessed with the help of that is better assessed with the help of MRI. MRI can be done with or without positron emission tomography or PET scan. So if PET scan facility is available, it helps to differentiate between inflammatory or malignant enlargement of lymph nodes. Whenever lymph nodes are enlarged, MRI or CT scan cannot differentiate between whether the enlargement is because of inflammation or malignancy, but PET scan helps to differentiate between these two. That is major advantage of PET scan in patients of suspected cases of carcinoma, invasive carcinoma, cervix. If these facilities are not available, even contrast-enhanced computed tomography, CTs can also provides good results and helps in staging. CT scan also helps for the CT-guided lymph node biopsy for the confirmation of lymph node enlargement, whether it is because of neoplastic or inflammatory change. But if these facilities are not available, even ultrasonography also can play a major role in staging of the disease. Transvaginal sonography is associated with a small risk of bleeding, especially if it is a exophytic growth. Transrectal ultrasonography, that is why transrectal ultrasonography is also used by many centers. Along with that, always we need to do abdominal ultrasonography, especially for detection of lymph node enlargement or for the presence of hydronephrosis, which indicates ureteral obstruction because of malignancy. Now, one by one, we will see what are the changes. Stage 1 is confined to the cervix, cancer is confined to cervix, spread to body of the uterus or corpus is disregarded. That we need to understand, and it is same for both 2009 as well as 2018. So what is the main change is stage 1A is micro-invasive for both. Even now also we consider micro-invasive as stage 1A. Invasion less than or equal to 5 millimeter depth is the criteria to call it as stage 1A. Difference is previously there was invasion less than or equal to 5 millimeter in depth, as well as there was a criteria that horizontal dimension should be less than or equal to 7 millimeter, which has been removed in 2018. So now what we have is only the depth. Depth of invasion should be less than or equal to 5 millimeter to include the cases as micro-invasive cases as stage 1A. Its differentiation as stage 1A, 1 and 2 is same as for 2009, that less than or equal to 3 millimeter is stage 1A1, whereas more greater than 3 millimeter but less than or equal to 5 millimeter will be stage 1A2. So diagrammatically also we can see here 2009 there were two dimensions. One was how much is the invasion, depth of invasion, and other was the horizontal dimension. This horizontal dimension of 7 millimeter criteria has been removed in 2018 staging system. So why it has been removed? What is the reason? What are the reasons for removing horizontal spread in stage 1A as less than 7 millimeter? Reasons are it was seen that it is not reproducible by pathologists. poor reproducibility is there. Then it correlates, poor correlation is there with lymph node involvement as well as with the prognosis. So even if we consider less than 7 millimeter or greater than 7 millimeter, there is hardly any correlation with lymph node involvement as well as with the overall prognosis, and that is why it has been removed from the 2018 FIGO staging. Stage 1B is confined to cervix. Spread to corpus is again disregarded here also, and the invasion is greater than 5 millimeter. Then it becomes stage 1B. 2009, as I said earlier, there was subgroups were only two, 1 and 2, less than 4 centimeter, greater than or equal to 4 centimeters. But by new staging system 2018, there are three subgroups: stage 1B1, stage 1B2, and stage 1B3. Now here for postgraduate students, you always remember that first one is Roman 1. Then there is a capital A, B, C, whatever is the stage. Next is a numerical one. That is how you should always be writing the staging of cancer cervix. Stage 1B1 is when the invasion is greater than 5 millimeters but less than 2 centimeters in maximum diameter. That is important, in maximum diameter. It is nothing like how much is the lateral extension. One has to measure maximum diameter of the lesion, and if it is less than 2 centimeters, it is stage 1B1. If it is more than or equal to 2 but less than 4 centimeters, it is stage 1B2. Any lesion which is greater than or equal to 4 centimeters but it is confined to cervix with a spread to corpus disregarded, it will be stage 1B3. So that is the main difference. So even here also diagrammatically, that there were only two subgroups in 2009, whereas now there are three subgroups: 1, 2, and 3, 2 centimeter, 2 to 4, and greater than 4. Now, important footnote has been given in this FIGO 2018 staging. Radiology or pathology findings, if available, can be considered along with clinical findings to decide staging is number one. So these findings are mainly for the assessment of tumor size as well as to see whether there is a invasion to the vagina or parametrium. Pathology findings are given more importance than clinical or radiology findings whenever available to decide the stage. Is an important thing, that if we have radiology findings, clinical findings as well as pathology findings, then more importance or precedence is to be given to pathology findings as compared to clinical or radiology findings to decide or allocate the stage to the given patient. In case pathology is not available, radiology findings are given more importance than clinical findings to decide the stage. So least reliable are clinical, then comes radiology, and most reliable are pathology findings to decide the staging. Lymphovascular invasion is not taken into consideration while deciding the stage. That means the lymphovascular invasion doesn't change the stage. Lateral extent of the lesion is also not considered while deciding the staging. What is included is maximum diameter of the tumor is taken as the tumor size. So hierarchy of various modalities to stage cancer cervix as per FIGO 2018. Number one is pathology. If it is not available, then we have to rely on radiology findings. Both not available, then we can stage the disease as per clinical findings. Stage 2 is same in 2009 and 2018 staging. Spread beyond cervix but not involving lower one-third of vagina or lateral pelvic wall. 2A is whenever there is involvement of vagina restricted to upper two-third and there is no parametrial invasion, which is further divided as 2A1 and 2 as less than or equal to 4 centimeter and 2 is greater than 4 centimeters. Stage 2B is parametrial invasion. But important changes in 2018, staging can be changed by imaging modalities. Imaging findings can be taken into consideration for to change the staging by 2000 is the change in the 2018. That means if the imaging indicates that there is an involvement of vagina or parametrium, accordingly we can change the staging. In stage 3, there is a main change is criteria for stage 3. 2009, it was only the involvement of lower one-third of vagina or lateral pelvic wall or ureteric involvement, which is seen by presence of hydronephrosis or non-functioning kidney with no other cause for that, either hydronephrosis or non-functioning kidney. But now there is a new addition in 2018, where along with all these, that is involvement of lower one-third of vagina or lateral pelvic wall or ureteric involvement, there is also addition of presence of para-aortic or pelvic lymph node metastasis or micro-metastasis. Definition of micro-metastasis is when the pathologist looks at the specimen, and if there is a presence of small clusters and each which are less than 0.2 millimeter in diameter, then multiple clusters with less than 0.2 millimeter in diameter, it is called as micrometastasis. So even if there is no lymph node enlargement, presence of micrometastasis also is considered under the stage 3. That is new addition or in the criteria for stage 3. Previously, stage 3 was divided in two subgroups only. Stage 3A, where involvement of vagina at lower one-third, and stage 3B is lateral pelvic wall involvement up to the pelvic wall, parametrial invasion up to the pelvic wall, or hydronephrosis or malfunctioning kidney because of the ureteric obstruction because of the malignancy. But now there are three subgroups. A and B are same. C is lymph node presence of lymph node metastasis or micrometastasis, and this is what is most important is it is irrespective of tumor size or extent. So even if it is a very small tumor, less than 2 centimeters, and it is showing presence of lymph nodes, directly the stage will change to stage 3C. That is why this important addition is there, that it is irrespective of tumor size or extent of the tumor. C1 is presence of pelvic lymph nodes only, whereas C2 is whenever stage 3 C2 is whenever there is a para-aortic lymph node metastasis is present. Now, whenever this is commented upon that there is a presence of either pelvic or para-aortic lymph node metastasis, whether it is being commented with the help of radiology or pathology needs to be denoted by mentioning either as 3C1R or P. R is where the imaging modality has helped in the detection of pelvic lymph nodes, or P is with the help of histopathology. Similarly, for para-aortic also, R or P needs to be mentioned. So, on what basis we are allocating this staging, whether it is with the help of imaging modality or pathology, that needs to be mentioned whenever we are categorizing the patient as per this new 2018 staging into stage 3C. One is for pelvic lymph node only, two is for para-aortic lymph node involvement. But here again, more importance is to be given to pathology findings as compared to radiology findings if in case there is a conflict in this. Stage 4 is same as in 2009. It is same for 2018 also, that there is a spread to adjacent and distant organs. If there is a spread to bladder or rectum, it is stage 4A. Spread outside pelvis to distant organs is stage 4B. Again, for this also, what is the change is 2018 staging can be changed by imaging findings. So if imaging shows CT scan, MRI, so it indicates that there is an involvement of either bladder or rectum or there is involvement of distant organs. Accordingly, staging can be changed. Now, what is the implication of change in stage 1B? As we have already seen, the previous 2009, there were only two subgroups, but now there are three subgroups. So what is the clinical importance for us gynecologists is stage B1 is when there is an invasion more than 5 millimeter, but it is less than 2 centimeters. Now, this stage is suitable for fertility sparing surgery is the most important reason why the change in 2018 classification in stage 1B has been done, because with this, when size is less than 2 centimeters, the chances of recurrence are less. On the other hand, with fertility sparing surgery, recurrence is too high with the stage 1B, 2 or 3, and that is why it is not recommended. Fertility sparing surgery as per the latest or recent evidence, it is only advantageous. The decision to proceed with fertility sparing surgery, that will be mainly for stage 1B1 where the size is less than 2 centimeters. Anytime size is more than or equal to 2 centimeters, these cases are not good candidates for fertility sparing surgery because chances of recurrence are too high. Stage 1B1 and 2 are for surgical treatment without need of adjuvant therapy. But stage 1B3, yeah, that is when your size is greater than 4 centimeters, it is best treated by chemo radiation. So this is the practical significance. So treatment strategy as per FIGO 2018, as we have already seen, stage 1B1 is when the size is greater than invasion more than 5 millimeter depth of invasion, but size is less than 2 centimeters. Then in these cases, surgery can be done provided a patient is a good candidate for surgery. But for stage 1B1, we can consider fertility sparing surgery if the patient needs that. But on the other hand, for stage 1B2, size being greater than or equal to 2 centimeters, then in these cases, fertility sparing surgery is not currently advocated. Whereas for stage 1B3, whenever the size is greater than 4 or equal to 4 centimeters, then chemo radiation is the best modality of treatment. So we have three modalities, either surgery, radiation, chemotherapy, and usually chemotherapy and radiation are given together. That is why it is called as chemoradiation. So we have then mainly two modalities for treating the patients, chemoradiation or surgery. And for that, this subgrouping of stage 1B in three groups helps to decide whether to proceed with fertility sparing surgery or not. Now, why addition of stage 3C, which was not there, lymph node involvement was not mentioned in the previous classification or staging by 2009. Lymph node involvement is a major prognostic factor. It is not given importance in 2009 staging. Lymph node involvement is a direct indication for chemoradiation even in otherwise operable cases. By 2009, what happened was surgery needed to be followed by chemoradiation because of lymph node involvement in many cases that patients were initially considered as good candidates for surgery. But then after post-surgery, when lymph node involvement was detected, then they needed additional chemoradiation apart from being subjected to surgery also. Surgery plus chemoradiation increases treatment related morbidity. That is why we want to reduce this treatment related morbidity, and that is the reason in 2018 this new addition of 3C is done, so that there is a reduction in the need of adjuvant chemoradiation. That is surgery followed by chemoradiation, that need reduces with this 2018 classification. It also improves prognosis of the patients by correct modality of the treatment being chosen at the start of the treatment planning only. Para-aortic or pelvic lymph node sampling nowadays can be done by Either minimally invasive surgery such as laparoscopically it can be done or CT guided biopsies also can be taken. And radiation also can be planned as per whether it is a stage 3C1 or 2. That means if para-aortic lymph node involvement is there, then only the radiation should be including that area. Otherwise, only radiation restricted to pelvic area suffices. And that is why this sub-classification helps radiation experts also, radiotherapists also, to plan the radiotherapy. Now, what were the major limitations of clinical staging or FIGO 2019? I'm sorry, FIGO 2009. Inaccurate assessment of tumor size by clinical examination. That was the main drawback. Many a times there was an underestimation of the size because infiltrative growth especially. It is difficult to assess the tumor size only on the basis of clinical examination. Similarly, ulcerative also gives a false impression of a small size. Inability to assess pelvic or para-aortic lymph nodes clinically. These were the two major drawbacks. So it resulted in understaging of the disease from stage 1B right up to stage 3. Many cases of 1B changed to 2B or 3C with better imaging findings which were allowed to change the staging by 2018. Overstaging was also common with stage 3B, that with the imaging it was found that up to the pelvic wall clinically, but then when you take the help of imaging, it changes to 2B in many cases. So that was also another drawback of this FIGO 2009 as compared to 2018 staging. Now, if we just look at the lymph node metastasis, this is a list for pelvic lymph node as per the staging, and this is para-aortic. So, as the stage advances, the possibility of lymph node metastasis keeps on increasing. But what is important is even 1B, chances of pelvic lymph node metastasis are 12 to 20%. Even para-aortic 4 to 7% for stage 1. And with stage 2 it increases to further increases both for pelvic as well as para-aortic, and that is how there is a change in the staging. We can see here only so many 20%, around 12 to 20% cases of 1B because of presence of pelvic lymph node will be now staged as 3C. Minimal invasive surgery or image or CT guided lymph node biopsy is done before deciding the staging of according to 2018 for pelvic or para-aortic lymph node sampling, as well as use of MRI, CT, ultrasonography or PET scan for tumor size, parametric invasion, vaginal involvement or lymph node involvement also helps for the correct staging. And what is seen is around 40% are upstaged from 1B to 3. That has been that retrospective analysis of the cases was done to apply this criteria for 2018 to the cases which were treated as per 2009. It was seen that there was so much of down staging, especially for 1B also. So if it is diagnosed as 1B by 2009, here as you can see, now if MRI shows that there is a vaginal parameter, there is a involvement of the parametrium, then it will be changed from 1B to 2B because there is a parametric invasion seen by MRI or with the help of CT scan. Similarly, if it shows that there is a presence of pelvic lymph nodes, then it from 1B it will directly go to 3C. If presence of para-aortic lymph nodes is metastasis is diagnosed by either radiology pathology, it will be upstage from 1B to 3C 2 directly. So that is how the 1B only is so many cases are getting converted, around 40% are getting converted, and they are being given a higher stage which helps in proper treatment modality, initiation of correct treatment modality, and it improves the overall prognosis of the patient is the main advantage of this FIGO 2018 staging. Procedure of stage allocation is we should do the clinical examination, inspection and palpation. Examination under anesthesia is always better for deciding the stage of carcinoma cervix, especially whether there is a vaginal involvement, parametrial involvement is better assessed when we examine the patient under anesthesia. Endocervical curettage and biopsy needs to be taken from the visible lesion for confirmation of the diagnosis. Permitted investigations are cystoscopy, IVP, barium enema study, proctosigmoidoscopy, colposcopy for early stage disease, but the confirmation of the malignancy is needed by taking a biopsy, even if you diagnose it with the colposcopy. Chest X-ray, ECG, and bone scans if there is a possibility of having distant bone metastasis. Along with that, in 2018, what is permitted now is CT scan, MRI, ultrasonography, PET as per the resources. These can be used for the staging of carcinoma cervix. CT guided lymph node biopsies will help us to again decide whether there is a change in the staging to stage 3C. Laparoscopically also, one can take para-aortic and pelvic lymph node biopsies or can do the lymphadenectomy and confirm whether there are metastases here. So that is how the stage allocation is advised as per 2018 staging. If radical surgery is done, always final allocation of the stages as per pathology findings after radical surgery, which depends on tumor size, presence of or absence of parametrial vaginal invasion as per the pathology findings, lymph node metastasis and micro-metastasis. Conclusion is 2018 staging is better in deciding treatment modality. It needs equal contribution of gynecologist, radiologist and pathologist for allocation of the stage. It correlates better with prognosis as compared to the previous 2009 staging. In case of doubt, earlier stage should always be allocated. Thank you so much.